Thank you. And I also would like to thank Dr. Wee for making us drunk and for the invitation. This is really kind. I would like to take you to a trip around your brain, and what I would like to show you is our fancy transcranial Doppler signals and some brand new video recording, which you probably haven't seen an operating room if you haven't paid attention to the TCD screen. But this is the middle cerebral artery, the blue is the ACA, and again, I think the secret of TCD that you see the presence, the depth, and the direction of the flow, and you can also, I think, from the resistance, you can tell lots of information. This is how an embolus looks like. And one of my favorite studies done by my favorite student showed these new lesions after CAS and CA, definitely where there's more lesion during the CAS, and the number of the lesions are more, but I think what I would like to show is what the real-time monitoring in the operating room helps us. And what you see now is, again, why you would like to shunt. We have a clamp placement. In the real time, I'm going to show you what happens to the middle cerebral artery flow. It just disappears. Tells you there's no collaterals whatsoever. The second reason why we'd like to do selective shunting, because when you do the shunt placement, you have a shower of embolization. And this is the time, again, you establish some little bit of flow, but you never get back to the 100%. When you walk through each step of the CEA, you will see how the flow just disappears when you have no collaterals, but the flow appears and retrieve collaterals, and these are the cases when no shunt needed. And look at the embolization difference just between these two cases, but also at the end of the surgery, there dramatically decreased embolization with the selective no shunt cases. Very important, when you put the shunt in, there's no other information than just a TCD can tell you if the shunt is even working. This is the case when the shunt is placed, but there's no flow by the shunt. The most important part at the end of the surgery, you would like to see except when you see the improvement of the flow, this is when you are comfortable leaving the operating room. If you do not see that improvement of the flow, out of the 100 cases what we just reviewed, we had 3 reoperation when we had to reestablish a flow and a flow improvement before we closed the skin. The second part, I would like to show you what we see during the carotid stenting. And this was our idea that we put 2 transcranial Doppler probes before and after the filter, and we can see how the filter is working. So disappointingly, 80% of the emboli can pass those filters. When you use proximal protection balloons, you may avoid all these embolization, what you see when the stent is placed. The most important question everybody would like to know, including me, gas and solid almost 50-50 by a dual frequency transcranial Doppler probe. But this is the most important pictures what I would like to show you. Look at this blunted MCA. When a stent is placed, you see the immediate improvement of the flow. On the other side, I'm monitoring the anterior cerebral artery. The anterior cerebral artery flow is not needed anymore because you established the flow in a carotid, so the collaterals is fading out. So the decrease of the ACA and the improvement of the middle cerebral artery flow, that's kind of confirming that you did something good to that carotid artery. The second part is, again, when we're doing the dilatation, we can see that when we do not have a flow, so you can quickly deflate your balloon and you don't wait for too long when you run asystole. We're going to skip the proximal protection, and this is in real time a middle cerebral artery occlusion. So that's one more reason to monitor that here's the flow and suddenly it's gone. So no more flow, and this is the high resistance flow pattern. You don't need neuro exam. I can tell you that middle cerebral artery is occluded, and I never saw an asymptomatic middle cerebral artery occlusion. And because the TAVI is one of our new procedure, I just need to show you what happens when the core valve passing through the arch, and when it's passing through the arch, pay attention to the right and the left side. Suddenly you're going to see embolization on the left side, and the left side signal going to disappear. This is when we reach the origin. And small number of emboli, but after that, the signal never going to return. And 30 minutes later, again, we successfully retrieved the clot with the clot retriever device. For patient selection, I'm sorry I'm running out of time, but I would like to definitely save Dr. Spence with his own slide, because I think that's the one more important data on the collaterals. If you do not have collaterals, we don't want just to screen for carotid stenosis, but for collaterals. If you don't have collaterals, you have 50% chance that you may die in a year. Thank you.